Great. Well, welcome everyone to this month's Collaborative for Accountability and Improvement webinar. Our focus today will be on the National Movement for Communication and Resolution Programs. I'm Melissa Parkerton. I'm the Assistant Director of the Collaborative for Accountability and Improvement, or CAI, and the Director of the Pathway to Accountability, Compassion, and Transparency, or PACT, which you will hear more about a little later in today's webinar. It is truly my honor to introduce today's incredible presenters, although my brief introductions will truly not do any of them justice. We will hear first today from Michelle Schreiber, who will talk with us about the Patient Safety Structural Measure. Dr. Schreiber is the Director of the Quality Measurement and Value-Based Incentives Group at CMS. In addition to being a general internal medicine physician, she's also served in numerous healthcare quality roles and has worked to move the safety needle forward for the country. Following Dr. Schreiber, we will hear from Julie Morath about the PCAST report. Ms. Morath is an executive coach and consultant on leadership, patient safety, and quality improvement. She's a founding member of the Lucian Leap Institute, was elected to the Board of Commissioners of the Joint Commission, and founded and served as president and CEO of the Hospital Quality Institute. She's also past president of the CAI Board of Directors. Next, we'll hear from Jeffrey Salvon-Harman, who will talk with us about the National Action Plan to Advance Patient Safety. Dr. Salvon-Harman is the Vice President for Safety at the Institute for Healthcare Improvement. His career has included serving as Chief Patient Safety Officer and Vice President at Presbyterian Healthcare in New Mexico, and numerous roles with the Indian Health Service and U.S. Coast Guard. Dr. Salvon-Harman serves as core faculty and a convening partner of PACT. Then Thomas Gallagher will discuss the proposed ACGME institutional requirements. Dr. Gallagher is the Executive Director of CAI and Associate Chair for Patient Care Quality, Safety, and Value at the University of Washington, where he also serves as a professor in the Departments of Medicine and Bioethics and Humanities. Dr. Gallagher was a co-founder of PACT and continues to serve as core faculty and a convening partner. Lastly, we will hear from Evan Benjamin about support for CRP implementation with PACT. Dr. Benjamin co-founded PACT with Dr. Gallagher and also continues as core faculty and convening partner. He's the Director of Community Innovation at Ariadne Labs, a joint center of healthcare innovation and at the Harvard School of Public Health and Brigham and Women's Hospital. And he's an associate professor of medicine at the Harvard Medical School and associate professor of health policy and management at the Harvard School of Public Health. During today's presentations, questions may occur to you. We invite you to put those into the chat at any time. We will then address as many of them as we can at the end of today's webinar. And with that, Michelle, I turn it over to you.
Thank you very much, Melissa. It's really a pleasure to be here today. I'd like to first say thank you to many of the panelists who've really put a lot of work and much of their careers into developing communication and resolution tools. I've long been a fan. I used to work on the Michigan Hospital Association Keystone initiatives where Rick Boothman sat. And I remember his early research showing that, you know, if you're transparent with patients and they really understand what happened, you are less likely to be sued. And frankly, that was pivotal work. So I've been a fan for a long time. Hopefully, as many of you are aware, CMS has finalized into the hospital rule the Patient Safety Structural Measure. This is an attestation measure that asks facilities about their underlying structures and commitment to patient safety. We all know that there is a lot of opportunity yet to improve in patient safety. The OIG report still showed 1 in 4 Medicare beneficiaries experiencing harm, and so we think it is vital to ensure that we are continuing to advance and accelerate our efforts around patient safety. Now, of note, the Patient Safety Structural Measure is fully aligned with other work that is going on, such as Safer Together, the National Action Plan to Advance Patient Safety, which has been put forward by both the IHI and AHRQ, and it aligns very closely. That was done quite intentionally. There are 5 domains to the Patient Safety Structural Measure, and facilities will have to attest to each of those domains, and will have to attest yes to each of the statements within those domains. There's usually 5 statements in order to score a point. So this is on a 1 to 5 scale, 1 full point for each of the domains. The first domain is around leadership commitment to eliminating preventable harm. The second domain is strategic planning and organizational policy. The third is around the culture of safety and learning health systems. The fourth is around accountability and transparency, and I'll circle back to that one in just a moment. And then the fifth is around patient and family engagement. Now, this clearly falls into patient and family engagement, but this particular question is in the category of accountability and transparency. So what this metric attests to, and I'm reading the wording, is that the hospital has a defined evidence-based communications and resolution program reliably implemented after harm events, such as AHRQ's Communication and Optimal Resolution Toolkit, i.e. CANDOR, that contains the following elements: that there's harm event identification, open and ongoing communication with patients and families about the harm event investigation, prevention and learning from it, and care for the caregiver. Finally, financial and non-financial reconciliation and patient and family engagement and ongoing support. In addition, the facility uses standard measures to track the performance of their communication and resolution program and reports these measures to the governing body, and by governing body, we mean the most senior governing body of the facility, reports at least quarterly. We hope that this will really engage more hospitals to be interested in communication and resolution programs, because we think open and transparent communication, problem solving, financial resolution where possible, upfront with patients is essential to really be reducing harm and for transparency so patients understand what has happened. We're very delighted, actually, that this was finalized into rules, and delighted to see that there is starting to be an uptake around some of the initiatives that are here, and I think that's true for communication and resolution programs. So with that, it's delightful to be here today, and I am going to pass to Julie Morath, who is going to talk about the President's Council of Advisors on Science and Technology report. Julie?
Thank you, Michelle. Good day to everyone. I am delighted to be here speaking with you. I would like to use slides so that the detail can carry with you as you want to refer to it. So my assignment is, Dr. Schreiber indicated, is to discuss the report to the President, a transformational effort on patient safety, which was placed on his desk in September. The hope was that this would become an executive order that he could sign and begin to put in place the recommendations of the report. Let me just outline for you what I hope to cover this morning. Next slide. What the role of PCAST, the President's Council of Advisors on Science and Technology, what it is, what the charge of the work group that has spent 2 years in formulating the recommendations that you'll see, provide a very high-level outline of the report as submitted to the President, because the report is geared to look at every recommendation in concert, instead of just taking one or another, that they all come together. But for the purpose today, we really want to reinforce CRPs. The background of PCAST. It's established by executive order, the President's Council of Advisors on Science and Technology, and it's an independent federal advisory committee. It's composed of individuals from industry, academics, and nonprofit sectors. A PCAST work group is appointed by PCAST to study a topic, solicit information from diverse stakeholders, and draft a report. To release a report, the full PCAST Council must make the decision in public, which includes discussion and voting. And we have included, for your reference, a direct link to the full report should you wish to pursue the detail. The recommendations must reflect the council's independent judgment, and as such, PCAST reports are not subject to any interagency review or approval process. Although the report, as it is emerging, is socialized with the agencies so that any landmines that might be uncovered are identified early, and we can resolve those issues. The reports are all public except if classified, and the ABC guidelines are followed. So A is that the president needs to have agency with the parts of the federal organization that will be directly affected. So a relationship of trust and common goal. The second is that the report must be actionable, clear, actionable activity. And the third is that the executive order of the report must be within the presidency period or launched so that it has sustainability beyond the president's term of office. The next slide shows you the members of the Patient Safety Work Group. There are 6 of us. And as you note, the members are quite diverse in our perspectives. And so we bring a very robust discussion to this work, hence the 2 years. But they are all synergistic. And each member has, and you'll recognize most of them, has spent their careers dedicated to patient safety. These are the agencies within the federal government that were involved. They were interviewed, they presented, and since the report has been on the president's desk, there have been several gatherings with the PCAST community to begin to explore how they might be able to effectively, efficiently, and in a coordinated system, begin to realize the recommendations that are contained in the report. Now on to the recommendations. The first recommendation is to establish and maintain federal leadership for the improvement of patient safety as a national priority. And points here are that there'd be a coordinator for patient safety reporting to the president and a multidisciplinary national patient safety team, which would include persons from populations most affected. This is parallel to the National Transportation Board. The second recommendation, and the first recommendation I might add, and it was very important to our patient and family advocates, is to answer the question, who's in charge? Where is the finest point of accountability? Recommendation 2, ensure that patients receive evidence-based practices for preventing harm and addressing risk. So that we're building a learning ecosystem with shared accountability, including response to harm. This is the point that's most exciting for CRP work, because it's called out specifically in the report. Ensure that evidence-based practices and CRP and PACT have been leaders in generating evidence as to what best practice is in responding to harm events for both providers, organizations, for patients, families, and the whole care team. So we're excited about this because the work that you're doing now will help us accelerate and spread and be very consistent with that was described to you from CMS. The detail I just put here is the language that actually is inside the report. So every time that Candor, developed by AHRQ, a federal agency, is referenced, it is in concert with CRP. So CRP, we think that working with you will be able to build out a robust playbook, if you will, training and opportunities to really connect around this work to best serve our patients and families who depend on us and our providers and care teams that are entrusted with their care. The next slide is recommendation 3. This, these all, if you see the themes connect to one another, is to partner with patients, reducing disparities in medical errors and adverse outcomes, which will take a whole of society approach. And this also requires data capture transparency to understand specifically what the disparities are. And as noted, 1 of 4 Medicare patients have suffered a harm during their hospitalization, disproportionately toward groups that often don't have a voice or their voice is not heard. And we feel obligated that this is understood. Recommendation 4 is also really important for PACT, because the acceleration of research and dissemination of evidence-based practices, technology, and system design is what we're about. So developing the National Patient Safety Research Agenda is a very important underscoring here. Harness and apply advances in information technologies, including AI, and using the federal healthcare delivery system to develop the capabilities and opportunities that can be implemented and then distributed and disseminated to the rest of the healthcare system in the United States. Now, because we're evidence generating and because we do research on this topic, we think that we'll be great contributors. Because in addition to the quantitative research, there's the need for the qualitative research that looks at experience. So 4 recommendations. Since these were made, the landscape has completely changed, and it's not clear what this would look like. We're still hoping that there'll be some executive action taken during the last period of time of President Biden's tenure. So the best I can think of to pass on, and has been helpful to me to calibrate, because this is going to require us to be very resilient as things change and the landscape is going to shift, is recruiting optimism. We need to be optimistic, and we have been, and it has produced results consistently. Leading with respect and dignity for all people. And that's where the trust comes in. And this intervention with PACT actually builds capacity and creates a climate within our organizations for ambient trust. Believing in the future of partnership, ethics, truth, and kindness, which are principles that come forward in all the CRP work. This is going to be difficult, and we're going to have challenges. So I think it's important that we remain connected in our community and grow our community for greater support, resolve, and ability to move forward these recommendations and the important work you're doing in CRP. With that, I'd like to turn it over to Jeff.
Thank you so very much, Julie. Good morning, good afternoon, everybody. It's good to be with you. Building on what you've heard from Michelle Schreiber about the patient safety structural measure and from Julie Morath about the PCAST report. I'm going to share information with you about Safer Together, a national action plan to advance patient safety, which you heard Michelle Schreiber referring to. Next slide, please. So I want to begin by framing what the Safer Together journey has looked like. In 2018, IHI, the Institute for Healthcare Improvement, and ARC, the Agency for Healthcare Research and Quality, came together in convening the National Steering Committee and co-chairing it. Over the course of 2 years, with membership from 27 different federal and industry and private partners making up the National Steering Committee, and developing working groups for each of the 4 foundational areas that appear in the National Action Plan, Safer Together came together. It was a consensus-based approach to identifying the key topics that are enabling for health systems to deliver safe care in the hands of a fully trained and competent workforce. And that product, that report, was published in early 2020. Unfortunately, not long thereafter, the COVID-19 pandemic impacted North America. And so Safer Together, a national action plan to advance patient safety, did not quite rise to the level of familiarity and visibility that was hoped for prior to the pandemic. Fast forward into 2023, and there are very strong influences observable in developing the patient safety structural measure by the Centers for Medicaid and Medicare Services. And in 2024, as we heard, the approval of the patient safety structural measure by CMS was announced, and with its 5 domains relative to the 4 foundational areas in the National Action Plan, having crosswalked the 2 instruments, we estimate about an 80% concordance of content areas and specific details in the patient safety structural measure as informed by the National Action Plan. Next slide, please. And so as we look at Safer Together in further detail, I want to share with you that there are 3 components to this National Action Plan to advance patient safety. And I'll call out as well, there's a very important semantics element in that title, a National Action Plan to advance patient safety, not the National Action Plan. And the reason for that is twofold. One is to say that other guidance may evolve over time that is complementary to it for the United States. But more importantly, in the present time, we view the National Action Plan we view a National Action Plan to advance patient safety as relevant for other countries as well, not just within the United States, that these are core principles of enabling safe care for any health system anywhere in the world. And so that gives it a transportability or a transferability, if you will, outside of the United States to be a guiding set of principles. And it complements nicely with the World Health Organization's Global Patient Safety Action Plan for 2021 to 2030. Now, within Safer Together, there are 3 components that are displayed here. First is the plan itself in narrative text format. And it defines the 4 foundational areas that you see in the upper right, and describes their interdependencies, that no one of them stands alone. All 4 of them interrelate, interact, and depend on the others for not only implementation, but for sustainment over time. So culture, leadership, and governance as relates to patient safety. Patient and family engagement, bringing the family voice in, as well as engaging patients and families as partners in their care for safer care. Workforce safety and well-being as it contributes to being at our best and doing our best work when we're on duty in healthcare. And then learning systems, where we're both acquiring data and learning from that data to glean those insights to improve our system design and produce safer care over time. And so in the middle the images, you'll see the self-assessment tool, which defines very specific elements within each of those foundational areas and assigns scores to those elements, such that any health system or individual facility or organization can assess themselves against these criteria and come out with a numeric score that helps them to identify where they benchmark against other organizations, as well as within the individual elements, highlighting where they have opportunities for improvement and growth, as well as highlighting their strengths to be able to celebrate within their organization and with patients, families, and their communities. And then the third cover of a document that you see is the Implementation Resource Guide, which is a curated set of resources related to each of the individual elements and their scoring criteria to provide guidance on who the key stakeholders are within organizations for that particular element, as well as ideas and references that would support implementation to move up higher in the maturity of that particular elemental process. I'll show you an example of that in just a moment. Let's go to the next slide, please. So this is a look at how CRPs are represented in Safer Together. In recommendation 9 of the action plan, we see specific key influencers, and I'll call your attention to tactics 9 Bravo, 9 Charlie, and 9 Delta that are descriptive of communication and resolution or reconciliation programs. On the left-hand side in light blue, you see who the key influencers are within an organization or a system for those components: senior leaders, safety and quality leaders, accreditors, regulators, governing bodies across the categories. And then the specific definition or direction of the tactic, which then has reference material in the Implementation Resource Guide. So this is showing you where CRPs fit within the National Action Plan as core components of one key recommendation of recommendation 9 to promote a culture of trust and respect for patients, families, and care partners. But we know that CRPs also have a benefit for workforce safety and well-being that I want to speak about for just a moment too. Because when we empower our workforce to have transparent communications with patients in the aftermath of an adverse event, when we allow and support our workforce members, our clinical teams, to be able to apologize without admitting guilt, but to issue that heartfelt apology for what has befallen the patient during the processes of care in complex environments, we know that that reduces moral distress and over time moral injury to the workforce. So it's also a component of workforce well-being that can have substantial impacts, not only in, as we heard from Michelle Schreiber, reducing litigation from adverse events, but also reducing turnover of our clinical staff by reducing burnout and moral injury. Let's go to the next slide, please. And so to give you an example of how the Safer Together self-assessment tool assesses across 4 different levels of maturity specific to communication and resolution programs, you can see on the bottom row, and I apologize for the font being a little bit small, that a score of 1 is given to an organization that does not have a CRP to respond to adverse events. A score of 2 is a defining of organizations that have made a commitment to CRP to respond to adverse events, but have not yet made it organizational policy. So there's a will and an intention, but not yet an action. A score of 3 corresponds to organizations that have a CRP in place to respond to adverse events, meaning that training is provided, that support is provided in real time when needed, and that all staff receive that benefit of training and guidance. And then a score 4 indicates not only that the organization has the program in place, but that support is available not only for the workforce in terms of second victim programs as we know them, like RISE and Code Lavender, but that there's also a support program in place for patients and families, not just a referral to behavioral health or seeking community resources, and that the program is regularly reviewed by senior leaders and the board, so it has full visibility throughout the organization. Next slide. So I want to spend a moment talking about the influence of Safer Together on some of the resources we've already heard about. Going into a little bit more detail from the PCAST report under recommendation 2B, I'll draw your eyes to the bottom of the paragraph where you see that specific language that Julie Morath had also included in her presentation around candor and communication and optimal resolution programs being identified by name by the President's Council. And that, I believe, is influenced very heavily by the work of PACT and its founders who are with us here today, Tom Gallagher and Evan Benjamin. I think that was also influenced significantly by the National Action Plan because of the inclusion of CRPs within the National Action Plan as well. Next slide. When we look at the patient safety structural measure, domain 4 specifically, as Michelle Schreiber had been reading out, is titled Accountability and Transparency. And of all of the individual attestation components within the PSSM, this is the one that goes into the furthest detail and has the most subcomponents to it, which I read as the best described and the least ambiguous. And so within this, you see the key elements that Michelle had read out to us around identifying harm, having open and ongoing communication, triggering our event learning processes. There is care for the caregiver, that reconciliation in financial and non-financial terms occurs, and the patient and family engagement and support is ongoing. It's not defined by an arbitrary time point, but it's seen through the lens of our patient activists and advocates of ending only when patients and families say that they are through, that they've completed the process. Next slide. And so final point I want to share with you about the National Action Plan is how it has led to creation of the National Action Alliance by the Agency for Healthcare Research and Quality, HRQ. These are the 5 aims of the National Action Alliance for patient and workforce safety. And you'll see a lot of similarity to the 4 recommendations in the PCAST report, as well as the 5 domains within the patient safety structural measure. Of advancing healthcare organization safety strategies using self-assessments. And so this is referring to the National Action Plan self-assessment tool, empowering the patient's voice and safety strategy, both through the learning of events as well as involvement in patient and family advisory councils, and the application of communication resolution programs, supporting the healthcare workforce by making healthcare safer by design, not by happenstance, not by coincidence, but through intention. Supporting the healthcare workforce by strengthening healthcare safety competencies and facilitating a learning and research network. I think that should all hearken as very familiar from the PCAST report. Next slide. And so the final element in the National Action Alliance is this bold aim that you see at the top in black. 50% reduction in harm by 2026 is the goal of the National Action Alliance. And the way that they foresee achieving that is through this combination of influence from the National Advisory Council and Federation and private partners who make up the National Action Alliance, healthcare organizations at the bottom foundational level performing self-assessments, and then interacting with the National Action Alliance through webinars or accessing tools and resources, implementation support, pursuing funding opportunities, joining affinity groups, and utilizing national healthcare safety measures. Those then roll up to healthcare organizations in the community where learning networks are forming, and there's identification, implementation of best practices informed through the Action Alliance and achieving value-based care. So it's a very bold goal, but it is driven by that foundation of the National Action Plan. Next slide. And so my closing thought for you before handing over is that communication and resolution programs are fully supported and aligned across national safety policy, initiatives, and measures. So with that, thank you for your time and attention, and it's my pleasure to hand over to Tom Gallagher.
Thanks so much, Jeff. And what you're hearing about today as the landscape for communication and resolution programs rapidly evolves is a host of new both recommendations as well as requirements. And these recommendations and especially requirements are really influential because healthcare organizations are beset by a panoply of things that they could work on, all important and worthwhile, to advance the quality, safety, patient-centeredness, equity of healthcare. And they have a difficult time choosing what are we going to prioritize. These recommendations and requirements play a major role in elevating a subset of initiatives to really mission critical status. And I'd like to talk with you about a proposed set of institutional requirements from the ACGME. The ACGME is the Accreditation Council for Graduate Medical Education. It's a private, nonprofit professional organization that's responsible for the accreditation of over 13,000 residency and fellowship programs, and at any given time oversees over 160,000 resident and fellow learners. So for any organization that has residents or fellows, the institutional requirements are critical because they basically define the structure, the resources, or the process elements that are essential for every GME or graduate medical education program to have. The next slide, please, Nicole. So the ACGME in the summer released what they called a proposed major revision to their institutional requirements. And one of the impetus for the major revision was recognition of the need for, in quotes, greater integration of GME and clinical learning environments to advance safety and improvement in healthcare organizations as they are being reshaped by the forces of health system transformation. These institutional requirements do lots of different things, but one of the things is they require sponsoring institutions. These are, it's a name for the locations where these training programs take place, to identify what are known as primary clinical learning environments, or PCLEs. These are locations within organizations where significant graduate medical education is occurring, and that are integrated with the organization's quality and safety and leadership infrastructure. The institutional requirements were very direct in their alignment with both PCAST and the patient safety structural measure, which I think is great. On the next slide, there are several requirements related to patient safety. And again, these are proposed requirements. But one is each PCLE must ensure new residents participate in non-simulated interprofessional processes addressing a real patient safety event. They require that each PCLE must have a patient safety and quality plan that integrates graduate medical education. And then this final one on the slide is, I think, really important, and I'll let you think some more about why this was added. At each PCLE, there must be policies and procedures outlining actions taken after the occurrence of a patient safety program and distinguishing the role of clinical patient safety program from the role of risk management. So again, distinguishing the role of patient safety from the role of risk management. Residents, fellows, and faculty must be provided with education on these policies and procedures. So what was it that ACGME is seeing as they spend time in these organizations that led them to add this language into the proposed revisions to the institutional requirements? On the next slide, it outlines the specific proposed requirements that are related to communication and resolution program. The current institutional requirements basically require that residents and fellows are provided with some experiential training in communicating with patients and families about patient safety event, and then that they, in quotes, seek to involve residents and fellows with faculty in harm event communications. The proposed requirements go much, much further. At each PCLE, there must be a program for responding to harm events that includes residents, fellows, and faculty members. The program must include residents and fellows and faculty members in communicating and seeking resolution with patients and families following harm events, and support provided to clinicians following harm. Why is this so influential? At many healthcare organizations that have residents and fellows, I think there's a nervousness to include the residents and fellows in the response to harm. And some of that is, I think, well-intentioned. They worry that involving emerging clinicians in what can be a challenging process might be difficult and harmful to their self-confidence. I think they worry a little bit that residents and fellows might not yet have the skills to communicate effectively with patients and families about harm events. But I think this reluctance to really engage the residents and fellows in this process, it leads to, graduates from these programs being unprepared as soon as they become attending physicians to really engage in the CRP process as effectively as might be desired. And it's also noteworthy here that the ACGME singled out not only residents and fellows, but also faculty, because they recognize that the faculty members, are not only sort of legally responsible for engaging patients and families in the response to harm, but they're largely the teachers and mentors for residents and fellows in this process. And I think there's an educational deficit for many faculty members around, well, what is a communication and resolution program? How does it work in my organization? What is my role? What are the resources that are available to support me? So by explicitly calling out residents, fellows, and faculty, explicitly calling out communication and resolution programs, these proposed requirements represent a major potential advance. So where are we now on the next slide? So the ACGME, as you might imagine, and this is just one of the many proposed revisions to the institutional requirements. They received a quote, robust response to the proposed revisions, which is great. And so ACGME is going to be extending the original timeline for approval and implementation of these institutional requirements so that they can align this effort with the upcoming revisions to another set of requirements that they call the Common Program Requirements that will be starting in January of 2025. And a second review and comment period will occur. I'm hopeful that the language on communication and resolution programs will survive. But regardless, it signals the intention of a really important accreditor in this space to support work on communication and resolution programs and recognition of its inclusion as a patient safety initiative. So with that, let me pass things over to Dr. Evan Benjamin, who will talk more about how the PACT program can support organizations in meeting these new recommendations and requirements. Evan?
Thank you so much, Tom. I just have to say, wow. And I just want to pause for a second and hope that all of you who have been participating in this webinar just take a deep breath. What we have just heard, right? We've heard about the momentum, which has been gaining strength, and the push for more being done in patient safety, and specifically to implement communication and resolution programs. All these recommendations and these requirements, we started with Michelle Schreiber talking about the CMS and the patient safety structural measures. That alone, there's so much to unpack there. We heard from Julie on PCAST and what the President's Council is making the specific recommendations and how CRP will fit into those patient safety recommendations. From Jeff on the National Action Plan and this National Action Alliance, which has been building for a number of years, to specifically talk about what we need to do to make healthcare safer and what the role is for CRP. And then finally, Tom, on ACGME and for organizations that have residency programs, what the ACGME is saying, we need to train the next generation in how to understand patient safety, how to communicate and support patients and staff. And so, boy, I mean, just think about all this coming together right now. So PACT, we came together, the Institute for Healthcare Improvement, the Collaborative for Accountability and Improvement, and Ariadne Labs came together to form a collaborative, a learning collaborative to help health systems implement the way they respond to harm, what we call communication and reconciliation programs. And we think that this work that we've been doing for the past number of years is uniquely suited to support health systems to be able to respond to everything that's happening nationally, this push, this alignment that you heard from my colleagues. We believe that our work in PACT can really help people. So what is PACT? The next slide shows our mission. We came together to inspire and guide healthcare organizations in their implementation of a highly reliable process to respond to patient harm. It's a learning collaborative. It uses tools to support that implementation. It uses resources, best practices, and it has a measurement approach to say, if you're doing this right, what does it look like? Those patient safety structural measures that you heard from Michelle, that's going to be a part of this. To say to your own board, we have a reliable process, and this is how we know because we measure it this way. Our mission was to create those measures and then support everyone in implementation. Next slide. So the collaborative is this learning community. It's now entering its third annual cycle. We've developed this learning community that has this collaborative structure taken from the IHI Breakthrough Series structure, where we come together with learning sessions, we have action periods, we have a core faculty that teaches the best practices in this 12-month curriculum, and then we share tools and resources to make this easy, because implementing an effective CRP is really hard work. It's really challenging. An effective CRP is all about, how do we learn about harm in our organization? How do we identify the harm? How do we then learn to prevent that harm? How do we support patients along the way? How do we support providers and those clinicians and staff who are involved in the event? This is really hard work. Most organizations are doing it in pieces, and what we've tried to do is bring it together in an approach. Next slide. So this is what that collaborative structure looks like, where we come together in these learning sessions. They're virtual sessions. Then they have these action periods in between these, but they go for about 2 months, where you're taking the tools and the best practices, you're doing those small tests of changes, a PDSA cycle in those action periods. We come back together. You're learning from a coach that we assign to each organization. You're also learning from each other and the broad faculty throughout this process. Next slide. So I mentioned the 3 organizations that we came together. We recognized the need in Jeff's work as the Vice President for Patient Safety and the work that you heard about the National Action Plan. They saw the need for a better implementation of CRP. The Collaborative for Accountability and Improvement has been on this journey for a long time, trying to improve transparency and accountability in healthcare writ large and specifically around CRP. And Ariadne Labs looks to improve healthcare delivery by trying to decrease the no-do gaps and think about scaling improvements in healthcare. And CRP has been my personal research mission for some time when I joined Ariadne. So next slide, we came together. Here's our core faculty. You've met almost all of us today, with the exception of Lager Sokol-Hessner, who's a clinical associate professor at the University of Washington, a real leader and thought leader in this field of CRP. And you saw Jeff and Tom and me and Melissa earlier. Next slide. Like improvers, we use driver diagrams. This is so lays out our curriculum of what we do. And this is how patient safety and CRP, it takes so many drivers to get to where you need to be. Leadership is so important as one of the primary drivers. We go through the best practices. How do you communicate to the board? How do you engage your board? How do you get senior leaders on board? We talk about high reliability processes, from event detection to communication. We have communication skills training. These are hard conversations to have. And then how do we learn the measurement and the learning systems? How do we actually learn about these events and prevent them from happening again, with ongoing training for the staff in not only communication, but in leading patient safety improvement? And then how do we work together in your organization and writ large around a community of practice to continue to advance this field, both internally as well as publicly? Next slide. We use a process map. I won't go through all of this, but we do each box that you see here. We put together a team, a CRP team. We go through the best practices of what happens in each of these boxes, and each organization makes this real for them. Who's involved at each of these levels? What are the best practices? And the number of tools that we put together support all of this. The next slide. These are just some of those tools and resources from measurement, which I mentioned. That will be so important with the patient safety structural measures, to be able to measure and report to your board. The communication tools, how to communicate about harm to patients and families, and keeping people in the loop and sharing the narrative and engaging patients. And then process tools. How do we actually do all these things? How do we do peer support? How do we move to an early resolution, a financial offer of compensation if it's necessary? And how do we engage patients along the way? So they know what's happening, that this is an organization that takes patient safety seriously, and I can see what's going to happen after a harm event. Next slide. So the measures, we look at what happens in an organization. We try to integrate this into safety event software. We use a harm scale. We ask organizations to report some measures so they can learn how they're doing. And those measures will be some of the same measures they can actually attest to that they're using in these patient safety structural measures from CMS. Next slide. So we've made tremendous progress. We've had 2 waves, 2 annual collaboratives. We're recruiting now for the 3rd annual collaborative. It's going to launch in February of 2025. We're taking applications through mid-January. Those who have been involved, we've had 28 healthcare organizations, over 50 healthcare facilities go through the PACT collaborative. They've developed their processes. They've created new patient family advisory councils. They've created their process maps. They've strengthened the way they do event review, how they how do they report these events, and the timeliness of what happens in terms of communication, and how do they support patients and then providers with peer support programs. Tremendous progress. It's been so gratifying to see the work through these 2 cycles of the PACT collaborative. And then next slide. We have a number of different health systems who have been involved. This is just a testimonial from Larry Smith. He's the Vice President of Risk Management at MedStar. MedStar actually joined us. They had a pretty mature program, but they really felt like they weren't doing it consistently. And Larry says here that many healthcare organizations believe that the right way to bring healing and resolution to patients and families when an unexpected and unwelcome outcome occurs is through honest, open, and ongoing communication. The PACT Collaborative can help any organization achieve success. MedStar was one of our first ones that went through. They made tremendous changes and really created a consistent approach to their patient safety work and how they respond to harm. So next slide, I'm going to just stop here. If you're interested in joining us, let us know. There's more information available both at Ariadne Labs. You can email us at pact@Ariadne Labs, as well as CAI. As I said, we're taking applications through January, and we'll be selecting those on a rolling basis, and we'll launch in February, around February 11th. You heard a lot over this past hour, so I'd like to just open it up for any questions that you heard from our speakers earlier about the patient safety structural measures, the PCAST report, the National Action Alliance, or our work in the PACT Collaborative. So we'll open it up there. You could come off mute. You could put a question into chat, and we can direct it to the right place.
And I will note that Kathleen has put a question in about looking at the importance of non-physicians with implementing a strong CRP. And I wonder if Tom, Evan, or Jeff, you want to speak to that?
The response to harm is at its core an interprofessional process. It's a team sport. Some of our early research in this area highlighted how nurses, for example, are an integral part of the process, but oftentimes feel left out, and how that omission causes enormous moral distress at the bedside for them when they're wondering, what has the patient or family been told? Patient and family is asking questions. They don't know how to respond. So this is an interprofessional process. And when it goes well, it really is a team sport.
Absolutely, Tom, that's well said. And I think our experiences when we're working with institutions, those that are getting it right really are bringing in clinicians as a multidisciplinary approach, from detection to event review to communication, and also to support. Staff who are involved are sometimes really traumatized by the harm that they were involved with. And it really requires a multidisciplinary approach to learn from these events and then to support one another.
If I might, Tom, and the comment you're making about interdisciplinary, intersectional, and team is so important. And my experience is that even the language non-physician talks about what people are not rather than what they are. And so I think some of our languaging could be much more empowering and positive using, Evan, the language you're using and that Tom's using, if we could make a habit of it.
I agree. I'm looking at the chat. Mary Stankos asks, how do hospitals work with HPL insurers to implement a CRP? Great question. And they need to work with their liability insurers. We have found that most of the liability insurers, the commercial ones, as well as the privately run insurance captives, are very interested in the approach of CRP. They believe that it is a path forward to support patients. They see the business case, as we mentioned earlier. I think it was mentioned that, you know, when we communicate, when we're transparent, we actually see a decrease in claims, a decrease in lawsuits, and it's, you know, the right thing to do. So most of these insurers and captives are very supportive, but it's really important when you're implementing a CRP to engage the insurers right up front. The privately run captives, usually the health systems have the board leadership, and they can control that messaging and usually get support. And then the commercial insurers, this is what Tom and I have been doing for years, talking to so many of the private insurers. bringing them on board, and they are coming on board. But it's a great question. It's super important to engage your liability insurers up front.
And that pretty much brings us to the top of the hour. So thank you all for joining us today. And please do reach out with any questions about PACT or anything else we talked about today.
Bye-bye. Thank you.